Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 187 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, RAJ, a 62-year-old female patient presents to your accident and emergency department. Her chief complaint is flank pain, nausea, vomiting, and subjective fevers at home over the last 24 hours. She reports recent decreased oral intake secondary to nausea and vomiting. She has a past medical history significant for right-sided cerebrovascular accident with residual left-sided deficits 2 years ago, urinary retention complicated by recurrent urinary tract infections, UTIs, DVT, PE with resulting right heart strain, hyperlipidemia, atrial fibrillation, and heart failure with preserved ejection fraction, abbreviated as HFpEF. Her basic chemistry includes sodium levels of 133 milliequivalents per liter, a BUN of 30 mg per deciliter, a serum creatinine of 1.2 mg per deciliter, and an estimated creatinine clearance of 60 ml per minute. Her pertinent vitals in the accident and emergency department include the fact that RAJ is confused. She has a body temperature of 101.3 degrees Fahrenheit, a heart rate of 100 beats per minute, a respiratory rate of 22 breaths per minute, an SBP of 100 mm of mercury, and an MAP of 70 mm of mercury. When discussing the details of RAJ's case with her primary physician, which of the following findings in addition to RAJ's initial presentation would provide the most convincing evidence of a urinary source of infection warranting treatment? Would it be A. Pyuria, or B. dysuria, or C. hematuria, or would it be D. bacteriuria? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. dysuria. Bacteriuria may be symptomatic or asymptomatic, but the presence of bacteriuria without symptoms is not sufficient to make a diagnosis of UTI. Hematuria varies in prevalence and lacks specificity for a diagnosis of UTI. It should not be used as the sole criterion for treatment. The presence of hematuria would not be the most convincing evidence of a urinary source of infection in this patient. Symptoms differentiate asymptomatic bacteriuria from UTI. The presence of dysuria would be the most convincing evidence of a urinary source of infection in this patient. Pyuria varies in prevalence and lacks specificity for a diagnosis of UTI. It should not be used as the sole criterion for treatment. The presence of pyuria would not be the most convincing evidence of a urinary source of infection in this patient. Please advance to the next question. And the next question reads, since the time of admission IAJ was empirically treated for possible pyelonephritis with ceftriaxone 1 gram IV infused over 30 minutes every 24 hours. Assuming that she is now afebrile and tolerating oral medications, and that her symptoms are responding well to antibiotic therapy on hospital day 3, which of the following oral regimens would be the most appropriate IV to oral switch to treat her urinary tract infection, UTI? Would it be A. nitrofurantoin macrocrystalline 100 mg orally twice daily for 4 additional days, or B. fosfomycin trimethymine 3 grams every 72 hours for 7 additional days, or C. ciprofloxacin 500 mg orally twice daily for 4 additional days, or would it be D. co-amoxiclav 500 mg, 125 mg orally thrice daily for 7 additional days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Ciprofloxacin 500 mg orally twice daily for 4 additional days. Oral beta-lactam antibiotics are less effective than other available oral agents for the treatment of pyelonephritis and should be avoided when possible. Therefore, amoxicillin clavulanate is not a good choice for this patient. Trimethoprim, sulfamethoxazole or fluoroquinolones would be appropriate oral options for uncomplicated pyelonephritis. Fosfomycin trimethymine oral sachets should not generally be used for the treatment of pyelonephritis or febrile UTI because of low concentrations outside the urinary bladder. Pathogen MIC breakpoints are indexed to urinary concentrations. There is no evidence that extending the duration of fosfomycin treatment to 10 days will improve efficacy. Ciprofloxacin has been studied in adult female patients with complicated UTI and pyelonephritis. A total of 7 days of treatment appears non-inferior in efficacy to 14 days of treatment. This patient's clinical status is rapidly improving. Therefore, 4 additional days of ciprofloxacin for a total of 7 days of therapy is appropriate. While fluoroquinolones should be avoided when effective alternatives exist, withholding effective therapy does not represent optimal antimicrobial stewardship. Nitrofurantoin should not generally be used for the treatment of pyelonephritis or febrile UTI because of low concentrations outside the urinary bladder. Pathogen MIC breakpoints are indexed to urinary concentrations. There is no evidence that extending the duration of nitrofurantoin treatment to 10 days will improve efficacy in pyelonephritis. And the next question reads, later in the day on hospital day 3, RAJ is scheduled to receive her final dose of IV ceftriaxone therapy, 2 doses received to date prior to her planned IV to oral conversion. The medical team is concerned about a new non-pruritic rash that RAJ has developed on her abdomen which has slowly spread across her upper torso, thought to be caused by the ceftriaxone. Her urine culture is growing 50,000 colony-forming units per milliliter of extended-spectrum beta-lactamase, ESBL producing Escherichia coli from a clean catch specimen. So my question to you is, which of the antibiotic therapies listed below would be the most appropriate to initiate for treatment of RAJ's complicated urinary tract infection, UTI after discontinuing ceftriaxone? Would it be A. ertapenem 1 gram IV infused over 30 minutes every 24 hours for 5 days that is a total active duration of 5 days, or B. Ceftazidime, tazobactam 1000 mg/ 500 mg IV infused over 1 hour thrice daily for 5 days, that is a total active duration of 5 days, or c. Ceftazidime, avibactam 2000 mg/ 500 mg IV infused over 2 hours thrice daily for 7 days, that is a total active duration of 7 days, or would it be d. Meropenem 1 gram IV infused over 3 hours thrice daily for 7 days, that is a total active duration of 7 days. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Meropenem 1 gram IV infused over 3 hours thrice daily for 7 days, that is a total active duration of 7 days. Meropenem is the best choice because this patient has an ESBL-producing organism in her urine culture and is symptomatic. Additionally, the patient had a reaction possibly due to a cephalosporin, so a non-cephalosporin is appropriate. The total duration of antibiotic treatment should be at least 7 days in this patient with a complicated UTI, i.e., pyelonephritis. Ceftazidime tazobactam might be a reasonable choice because this patient has an ESBL-producing organisms in her urine culture and is symptomatic. However, she had a reaction possibly due to a cephalosporin, so a non-cephalosporin is appropriate. The use of a very broad spectrum of antimicrobial with activity against carbapenem-resistant Enterobacteriaceae in a patient who may respond to a carbapenem does not represent optimal antimicrobial stewardship. Ceftazidime tazobactam might be a reasonable choice because this patient has an ESBL-producing organism in her urine culture and is symptomatic. However, she had a reaction possibly due to a cephalosporin, so a non-cephalosporin is appropriate. The total duration of antibiotic treatment should be at least 7 days, not 5 days in this patient with a complicated UTI, i.e., pyelonephritis. Ertapenem is a reasonable choice because this patient has an ESBL-producing organism in her urine culture and is symptomatic. Additionally, the patient had a reaction possibly due to a cephalosporin, so a non-cephalosporin is appropriate. However, the total duration of antibiotic treatment with a beta-lactam should be at least 7 days, not 5 days in this patient with a complicated UTI, i.e., pyelonephritis. Please advance to the next question. And the next question reads, RAJ's urologist is preparing to discharge her home. As the clinical pharmacist in the infectious diseases team, you do a thorough discharge medication reconciliation which reveals the following former oral home medications: rivaroxaban 20 mg once daily, atorvastatin 20 mg at night, metoprolol 50 mg twice daily, multivitamin with magnesium, zinc, and minerals once daily, and calcium plus vitamin D daily. The urologist would like to restart all of her home medications on discharge and requests you to counsel the patient on her new home medications. Assuming that oral ciprofloxacin is prescribed, which of the following would be the most appropriate recommendation for how RAJ should schedule her ciprofloxacin doses at home relative to her other medications? Is it A. Take ciprofloxacin 2 hours before or 6 hours after her rivaroxaban, or B. Take ciprofloxacin 2 hours before or 6 hours after her multivitamin, or C. Take ciprofloxacin 2 hours before or 2 hours after her atorvastatin, or is it D. Take ciprofloxacin 2 hours before or 2 hours after her calcium? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Take ciprofloxacin 2 hours before or 6 hours after her multivitamin. Ciprofloxacin should be taken at least 2 hours before or 6 hours after multivitamins and other products containing multivalent cations, e.g., calcium. Rivaroxaban and atorvastatin do not interact with ciprofloxacin. Please proceed to the next question. And the next question reads, RAJ returns to your accident and emergency department at your 28 days later. Her chief complaints include dysuria and urinary frequency, with abdominal fullness and bloating, multiple episodes with a large volume of watery diarrhea at home with an increase in frequency of episodes over the last 24 hours. Her urinalysis results reveal 3+ bacteria, greater than 100 white blood cells, 5 to 10 red blood cells, and less than 10 epithelial cells per high-powered field with a positive nitrite test. A Clostridioides difficile PCR test is ordered to evaluate her watery diarrhea. On admission, RAJ is a febrile and hemodynamically stable, has a serum creatinine of 1.3 mg per deciliter, a systemic WBC count of 22,000 cells per millimeter cubed. Urine culture and gram stain are ordered by the urologist. Considering RAJ's antibiotic exposure history and presentation, which of the following antibiotic regimens targeting her urinary tract infection would be most appropriate to initiate in RAJ now? Would it be A. Meropenem avibactam 2000 mg 2000 mg IV infused over 3 hours thrice daily, or B. Ertapenem 1 gram IV infused over 30 minutes once daily, or C. Cefepime 1 gram IV infused over 30 minutes thrice daily, or would it be D. Ciprofloxacin 400 mg IV infused over 30 minutes thrice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Ertapenem 1 gram IV infused over 30 minutes once daily. Recent hospitalization and ciprofloxacin exposure makes resistance to this drug likely, so it is not the best choice for RAJ. There is an increased risk for resistance if the same antibiotic was prescribed in the previous 90 days. Recent hospitalization and antibiotic exposure make antimicrobial resistance including extended-spectrum beta-lactamase producing Enterobacteriaceae likely in RAJ. However, cefepime is not a good choice for RAJ because clinical outcomes data do not consistently support activity of cefepime against serious infections caused by extended-spectrum beta-lactamase producing Enterobacteriaceae. This patient has a recent admission and received multiple antibiotics within the last 30 days, making antibiotic resistance to fluoroquinolones and cephalosporins likely. Management with ertapenem appears effective and reasonable for patients like RAJ with complicated urinary tract infection probably caused by extended-spectrum beta-lactamase producing Enterobacteriaceae. Although meropenem avibactam is likely to be active against extended-spectrum beta-lactamase producing Enterobacteriaceae which may be causing RAJ's infection, it has a broad antimicrobial spectrum of activity that includes carbapenem-resistant Enterobacteriaceae, abbreviated as CRE. It is not clear that antibiotic therapy with activity against CRE is warranted for this patient at this time. Please advance to the next question. And the next question reads, 90 days ago JKL suffered a closed right pilon, i.e., distal tibia, fracture requiring internal fixation. Regarding her social history, she is a single, working mother of 2 young children. She smokes cigarettes. JKL experienced postoperative complications like slow wound healing and occasional episodes of erythema and mild drainage treated with short courses of oral antibiotics over the past 90 days. 72 hours have elapsed following surgical incision and drainage. The surgeon was unable to remove the internal fixation hardware due to slow bone healing. 3 samples obtained while performing an intraoperative bone biopsy are growing methicillin-resistant Staphylococcus aureus, MRSA. The patient has a very comprehensive health insurance coverage and requests a postoperative antimicrobial drug which would be quick and easy to administer at home. Which of the following IV anti-MRSA agents can be administered over the shortest duration, which also provides the simplest regimen for use as outpatient parenteral antibiotic therapy (OPAT)? Is it A. vancomycin, or B. telavancin, or C. daptomycin, or is it D. ceftaroline? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. daptomycin. The recommended infusion time for ceftaroline is 5 to 30 minutes. However, ceftaroline is given every 8 to 12 hours for bone and joint infections. The optimal dosing interval has not been fully established in clinical trials, and the interval varies among case studies and case reports. Ceftaroline is stable at room temperature for 6 hours and under refrigeration for 24 hours. Infusion companies typically do not make daily deliveries to patients in the home, so this drug is not suitable for OPAT. Daptomycin is administered once daily for hardware-associated osteomyelitis caused by MRSA. It has bactericidal anti-MRSA activity. The drug can be administered IV push over 2 minutes, so it is the quickest and easiest OPAT for this patient. Reconstituted daptomycin is stable under refrigeration for up to 5 days, enabling infusion companies to prepare and deliver to the patient a supply that will last several days. Although telavancin can be administered once daily for hardware-associated osteomyelitis caused by MRSA, one of the potential adverse effects is infusion-related red man syndrome. This adverse effect can be exacerbated by rapid infusion, so the drug should not be given IV push. The recommended infusion time is 60 minutes. Vancomycin is the treatment of choice for hardware-associated osteomyelitis caused by MRSA, but the drug is given every 8 to 24 hours in patients with normal renal function. Rapid infusion is associated with red man syndrome, so the drug should not be given IV push. Recommended infusion times vary depending on the dose. The general rule is to avoid infusing 1 gram any faster than over 60 minutes. Vancomycin can be given as a continuous infusion, but that requires the patient to be tethered to an IV line 24 hours per day. Therefore, vancomycin is not the easiest drug to use for OPAT by this patient. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 188.